Good evening, and it's indeed a pleasure to be here in this evening and to introduce my dear batchmate, Pandula Athauda-arachchi. He's the interventional cardiologist at Durden's Hospital, Colombo. And Pandula has a very long and a very distinguished academic career. I met him in the 1993s, I think, during the Dulux DUNA competition before we came into the university. And he then went on to represent the country in the SARC quizzes as well, being a proud product of the Dharmaraj College Kandy. And then he attended attended our University of Peradeniya, Faculty of Medicine. And there he obtained first-class honors in all of the exams, as well as having 11 distinctions and 18 awards and prizes to his name during his academic career. And then he went on to join the University of Cambridge on an international Gates Cambridge scholarship, where he completed his PhD for outstanding academic merit. And then actually he has many publications in scientific journals, and he has presented his work in international forums, including the EuroPCR Congress in Paris, France, Barcelona, Spain in 2012. And he has many UK and European accreditations to his name, and has been awarded the Fellowship of European Society of Cardiology and for clinical excellence. He actually has an extensive knowledge and experience in coronary intervention, and aortic valve procedures, heart valve devices, as well as echo imaging, coronary CT, intravascular ultrasound, and rotoablation, laser-assisted angioplasty, and many cardiac interventions. And I'm actually really proud to have Pandula here, and I think he's a very important, he's an icon in our batch, as well as to the Faculty of Medicine. And I think this talk will be very interesting and practical. Especially he will be dealing with ischemic, analyzing chest pain and preserving cardiac function. And I hope that our students will benefit immensely from his talk and of the practical aspects of managing cardiac problems. Thank you very much, Pandula, and I would like to open the stage for you.
Niranjan, thank you very much for that kind introduction. I'm indeed honored to have had a good friend like you in my university days. We shared a lot of common interests, and so it is a privilege for me to come back to the university and inspire another generation of undergraduates. So as Niranjan said, I was in your place about 25 years ago, listening to all the profound professors who were giving us a lot of education and helping us develop our careers. Of course, we had limited knowledge and understanding where our training would take us and how our careers will pan. But on the other hand, it's very important for young doctors to see what they want to do, what they want to achieve in life, and then set their targets early in their career. So it's more important than ever to realize and develop an interest in whichever field that you want to take. And I think PeMSAA is doing a great job in organizing talks from various experts to understand and get the length and breadth of medicine and the medical specialties so that your careers will be illuminated in future. So the talk for today is about advanced interventional cardiac procedures, perioperative care required to prevent the epidemic of end-stage heart disease in Sri Lanka. Now, the reason why I'm interested in this is that heart failure tends to be one of the biggest threats to improving healthcare standards in Sri Lanka. And the bigger issue here is that if a patient comes to a casualty unit with a heart failure, pulmonary edema, the chances of that person leaving the hospital alive, drops by about 30%, even in the best units when they come in with end-stage heart failure. And then countries like Sri Lanka and India, the mortality is higher than that has been recorded in other countries. And you all know cardiovascular disease is the leading cause of morbidity and mortality in Sri Lanka and world. And before we dive into cardiovascular medicine, it is very important for us to understand the anatomic basis and the disease process by way of describing them according to the structures that we have identified during our clinical years. The muscle, the valves, the blood supply, the electric pathway, the lining, the pericardium, all contribute to different kind of diseases, and identifying them correctly and putting them on the right treatment track often saves life. Heart function is vital to all performance of all other organs in the body. When you talk about heart failure epidemic, American Heart Association will classify this as heart failure with low output. Low output, of course, now has been subsequently said reduced ejection fraction or preserved ejection fraction. Preserved ejection fraction is where you have got normal LV systolic function when calculated by echocardiography, but all the features or manifestations of heart failure are there, particularly because of the filling problems of diastolic relaxation of the heart. As you know, the blood flows into the heart during the diastolic phase, and then the blood is ejected out of the left ventricle during systole. So if the diastolic filling itself is a problem and the pressures tend to rise up, you will get the manifestation of heart failure, even though the primary pumping out activity is satisfactory. And there are also other certain causes of heart failure, which you can classify. High output heart failure. This is where you actually get a higher than normal cardiac failure, but it is not sufficient to maintain the bodily needs. So it could be due to low systemic vascular resistance, hypothyroidism, beriberi carcinoid anemia, and then eventually the heart tends to fail because it has to maintain a higher output. So it's a different kind of a pathophysiology. And then the isolated, the left ventricular failure is what we normally concentrate on, but right ventricular failure in isolation or as part of the process could present to you with different kind of clinical manifestations. The forward failure could happen because of the inadequate left ventricular filling as a consequence of right ventricular failure. So we will discuss this a little bit as we go along during the talk. So systolic dysfunction, systolic heart failure is predominantly the reduction of the heart pumping activity, forward pumping activity, brought on by a number of other reasons. The predominant reasons are coronary artery disease, cardiomyopathies, hypertension, and valvular heart disease. And then diastolic heart dysfunction, as I told you about the filling issues, generally hypertension, underlying diabetes, coronary artery disease, hypertrophic cardiomyopathy, restrictive cardiomyopathies, all will contribute to the stiffness of the left ventricle and therefore cause a diastolic dysfunction or heart failure with preserved ejection fraction. So this is a table, looking at roughly, in a unselected admission in a average hospital in India, where people with heart failure come in, and then if you were to calculate who has what underlying reasons for the heart failure, ischemic left ventricular dysfunction was the predominant. Dilated cardiomyopathy is followed by that. Rheumatic heart disease still carries a big burden in our country, but gradually the onus of this on heart function is reducing thanks to the better living standards. Infective endocarditis, post-valve surgery and valve interventions, again, they are on the rise because we tend to treat a lot more patients with surgical as well as catheter-based procedures. So that is also a concern for us to keep in our mind. Mitral valve prolapse, though considered mostly benign condition, is important. Eventually gives rise to mitral regurgitation. Pulmonary vascular disease is not uncommon in Sri Lanka. Primary pulmonary hypertension is a common presentation that leads to right heart failure. Aortic valve disease, again, quite common in the elderly patients as well as younger patients with the bicuspid valves. Heart failure with preserved ejection fraction, as we told about diastolic heart dysfunction, isolated diastolic heart dysfunction, again, can account for a certain number of patients. Endomyocardial fibrosis or Loeffler's syndrome, peripartum cardiomyopathy, aorta-arteritis, hypertrophic cardiomyopathy, constrictive pericardiomyopathy, all these are important pathophysiological entities that lead to heart failure in our part of the world. And then if you were to look at the natural history and consequences of heart failure, index event in heart failure with reduced ejection fraction is that you get an index event, and then the heart tries to compensate by pulling up the heart rate, contractility, trying to hypertrophy itself and increase the diastolic filling pressures, and then try to somehow maintain the function initially. But as a consequence of trying too hard, it eventually causes more adrenergic activity. Renin-angiotensin system gets active. The neurohormonal mechanisms go haywire, and eventually dysregulated myocyte gene expression leads to muscle death, program death, and fibrosis. And then eventually, as time goes on, patient succumbs to end-stage heart failure. Similarly, diastolic heart failure also with sustained pressure inside the chambers will lead to fibrosis, reactive oxidative species, and destruction. And then the associated factors that occur around with diastolic heart failure will also take its toll on the heart. So eventually the coronary artery disease, hypertension, valvular heart disease, obesity, diabetes, kidney disease, etc. will lead to compensatory changes in the heart. And the vessels and the heart muscle itself will try to remodel to a certain extent, and then this will build up, and then eventually will lead to early stage death due to either rhythm disorders that happen as the compensatory mechanisms take its toll on the heart. Eventually, the structural changes will also take place, and the heart will start stretching up, and then cause problems for the heart, and end up with structural enlarged heart, pump failure, and sudden death. So the biggest culprit in terms of causing heart failure is coronary artery disease. Now in South Asia, there's an epidemic of ischemic heart disease going on. You may be aware or may not be aware, but it is very striking that we get patients under the age of 30 presented into our emergency units with acute ST elevation myocardial infarctions. And in India, the percentage in 2015 was around 10.5. That's 1 in 10 were under the age of 30. That's a staggering number of patients, and then it's increased by about 27% compared to last 5 years. With the COVID situation, I think the number of STEMIs in younger patients also has gone up even further, and so often the confusion with other comorbidities leads to poor health provision and death in this age group as well. So in Western countries, of course, cardiovascular disease occurs mostly in the older age group, but in our part of the world, there's a troublesome trend that is seen where young people seem to be succumbing to heart disease. And my youngest patient who had acute MI was just 22 years old, in the left main occlusion from Kandy. So these things do happen, and then we have to be very careful about how we manage our population. Coronary artery disease, where you get occlusion of the coronary arteries due to a number of reasons. Starts at a teenage, when you're in your teens, and builds up to your young age, and eventually leads to complications. So you start getting the fatty streak, and then the oxidated lipids accumulate in the intima, causing atheroma, and the atheromatous cap, particularly the thin cap fibroatheroma, tend to rupture under the influence of various risk factors, including smoking, hypertension, physical activity, sudden shear stresses on the heart blood supply, and leads to thrombus formation and sudden occlusion of the coronary arteries. So when this happens, the disease process that we see could be a number of things. It will either be unstable angina, non-ST elevation MI, or myocardial infarction, which are actually a spectrum of the same disease process. The acute coronary, they are coming under the process of acute coronary syndromes. So acute coronary syndrome, when the substantial amount of heart muscle enzymes are not being detected, but you suspect that this process has happened, and is classified as a typical unstable angina, presents with a chest pain of recent onset or increasing symptoms frequency or severity. And then non-ST elevation MI is where you have evidence of myocyte necrosis with cardiac biomarkers associated with ECG changes. And then the proper ST elevation myocardial infarctions, where ST segments have gone up, which indicates complete occlusion of a coronary artery. The damage is quite marked at that point, and the risk of death is also marked in this particular subset of patients. And the impact for the left ventricular function is highest in the ST elevation MI group. Now, let us see, we think, we are in terms of South Asian countries, we provide a very good service, to our patients with cardiovascular disease. Yes, we do, but unfortunately, a lot of people do fall between the stools and then end up with, bad outcomes. This is a tragedy that I have seen recently. A 32-year-old man, not very old person, comes with shortness of breath on exertion, had some throat discomfort for more than 6 months on walking. And then he goes and sees a cardiologist, who does run a few tests and then finds out that his heart is dilated more than 7.5 centimeters. That's quite big. But, falsely assumes with his young age, the chances of coronary artery disease probably low, and he thinks this is probably a dilated cardiomyopathy. So the assumption is the biggest threat to making a firm diagnosis in these cases. And patient was managed as dilated cardiomyopathy with heart failure medications. And oddly enough, they also did a CT coronary angiogram, which demonstrated only mild single vessel coronary disease. But having analyzed this, I see that when the heart function is not so good, sometimes you end up, getting poor opacification of the coronary arteries, and then you tend to get a false reassurance that coronary arteries are actually not too bad, whereas occlusions cannot be properly seen. So we'll have a look at it, in a minute. Now, this patient came to me saying, can't walk 5 feet, can't lie flat, grim prognosis, saying that, you've got end-stage dilated cardiomyopathy, only medical treatment is possible. His heart function was 26%. This is how the heart looked like. What you see here is a speckle tracking on echocardiogram. This is a new tool where you can use to locate contractility of different segments of the heart based on echocardiographic appearance. And to me, looking at this speckle tract echo, I could say that there are multiple coronary artery territories, which are having a problem, and it doesn't look like to me like a typical dilated cardiomyopathy looking at this tracing alone. So I undertake a coronary angiogram, and this is what I see here. Okay, so what you see in the top panel is the left main coronary artery. You see my arrow going here, and there's a complete occlusion. The LAD that is supposed to be running here is completely occluded. The circumflex artery running on the back of the heart has got a critical 99% stenosis. This is the right coronary artery. Beyond the artery marginal branch, it is completely occluded again. I mean, this is a tragedy, absolute tragedy, because these are preventable and treatable causes of heart failure that we have missed out and then wasted time. So in the end, patient, was too sick to, go for further procedures. So in the end, we decided to go ahead and then treat this with angioplasty. What you see here is a intra-aortic balloon pump to support, because these are tricky procedures. With the heart function being so low, they can arrest during the revascularization procedure, either whether you do stenting procedure or bypass. We recanalize the left anterior descending artery and open up the left anterior, blocked the left anterior descending artery. Blocked right coronary artery was open. It was a diffuse disease downstream, but we got good flow. The circumflex artery was opened up. So how does this transpire? Patient's heart function improved afterwards. He was off the balloon pump. His heart function improved about 36%. He could walk to the toilet after a long time, went home 3 days. Long-term outcome is, of course, awaited, but we could have done much better if we had picked this patient up at an early stage and then treated. That's why I say, though we have a good system of cardiovascular provisions based on simple assumption that this could be this, but without actually testing it, we end up actually giving a bad service to our patients. I see this kind of cases on a daily basis. So as medical students, I urge you to start asking critical questions. There is a number of reasons for failing to make the diagnosis in time to get people properly be treated. You would have seen recently there was a case in Ratnapura where a junior in the diagnosis is a very, very important thing that we need to avoid. Intern doctor, and I was telling you in Ratnapura we had a case where a young man who came in who had a previous angiogram, and on the basis of that, chest pain was diagnosed to be gastritis, when the inferior ST elevation MI was happening. And then the doctor didn't actually see the ECG, and then assess the patient correctly, and the patient died. And then, of course, there was a huge uproar about the intern doctor. But the bottom line is, never assume things. It's always important each individual presentation that you take stock of it, and then make sure that you do a proper job to understand whether the patient is actually suffering a life-threatening condition before you walk away or assume based on previous findings. It's not easy, in a crowded hospital or clinic facilities to do this, but it's important to take stock of things when things are not sounding right. So you need to know how to analyze the symptomology as accurately as possible. Cardiac chest pain, acute chest discomfort, pressure, tightness, burning, all that is being used to describe cardiac sounding chest pain. Chest pain equivalent symptoms also must be taken into consideration: dyspnea, epigastric pain, pain in the left arm, pain in the jaw, pain in the back, throat discomfort, sometimes pain in the teeth. Could be cardiac pain. Very important, in the elderly or in the diabetic patients, never disregard the symptoms just based on clinical factors alone. It is very risky, because I have seen people sitting with ST elevation MI saying, "No, doctor, I have just got belly pain, nothing else, this is not a heart pain." But actually you can see that patients are having a heart attack. So it's very important to analyze this correctly. So you take a focused history. You don't spend hours, taking a history when somebody you suspect, somebody's having a heart attack. Past histories are important. Associated symptoms, chest pain, character, timing, radiation, exacerbating factors are very important. Exacerbation, if particularly with exercise, pain gets worse. That is a hallmark of cardiac pain. And then whether the pain gets better with nitrates or medications, you can ask, but it is not specific to cardiac pain alone, but is suggestive. So you need to know the different gradings of association of cardiac chest pain. And then whether the pain is getting increased in the severity and frequency, and whether it comes at rest, in which case, of course, acute coronary syndrome could be underlying. The cardiovascular risk factor profile assessment is very important. You need to know whether they had abnormal lipid profile. Family history is probably one of the most important contributory factors, because we cannot analyze the gene sequence and the gene expression of all individual families, but that is one of the strongest risk factors for coronary artery disease. And then when you ask these past medical history and the pain characteristics, if you suspect, then you go and do a focused physical exam, vital signs, the temperature, the pulse, the blood pressure in both arms, the patient's appearance itself, tenderness, neck veins, signs of heart failure, the extremities, cyanosis, hypoxia, breathlessness. All these things are very important to get a proper assessment of the patient's clinical status. You know that there's a categorization of New York Heart Association criteria for breathlessness. If you have a heart failure, you should be able to score based on looking at the patient's appearance and asking a few questions. You should be able to make a judgment about how hard the difficulty of breathing is with heart failure, if you suspect heart failure is there. Okay, so moving on from there, it is very important for you to differentiate this kind of pain with other competing severe life-threatening problems, as well as very common non-life-threatening problems. So the two things here, the orthopedic issues, and no disrespect with the orthopedic doctors, but orthopedic causes of chest pain and other disorders, they can cause severe pain similar to cardiac pain, but of course careful history taking, examination eliciting of tenderness, might give you an idea about other causes other than cardiovascular disease that is present in the patient. Myopericarditis, cardiomyopathies, tachyarrhythmia, heart failure, hypertensive emergencies, valve disease, Takotsubo, stress cardiomyopathy, which presents like a heart attack with elevated enzymes and ECG changes due to stress cardiomyopathy, coronary artery vasospasm, or cardiac trauma, blunt trauma, or sports injuries. Those things also can present like cardiac pain. So it's important to understand the mechanism and what sort of pain you are suspecting, and then elicit that in your history. And then pulmonary embolism is not uncommon, particularly in the setting of COVID patients. Tension pneumothorax, again, can cause cardiovascular compromise with hypoxia. So be aware of that. Those are life-threatening pulmonary conditions. Aortic dissection. We've had several patients with Marfan's syndrome, who had aortic dissections. If they were not properly immediately picked up, they could end up with all sorts of problems, including stroke, heart attack, as well as spinal paraplegia, and renal failure. So you need to think about if they've got sharp pain going down the back and the blood pressures are unequal on each side, immediately think about aortic dissection as a possibility. The gastrointestinal symptoms also very important. Patients, particularly who have a cardiac history, might be on aspirin and they might have esophagitis, they might have diabetes, and on metformin they get acid reflux. They may have coronary spasm as well as esophageal spasm, and then on top of it, they may have a penetrating peptic ulcer, anemia, pancreatitis, cholecystitis. All these things could potentially confuse your interpretation of the patient's symptoms. So carefully analyze these. It's very important, once you've taken a quick history and ECG assessment, you take a ECG interpretation. Your 12-lead ECG is the first diagnostic tool, but please pay attention to where you place the ECG leads. Sometimes leads are being switched by ECG technicians. You need to be able to identify that the leads have been switched. You must take a ECG within 10 minutes of arrival with acute chest pain if you suspect ST elevation MI. A qualified physician should be able to see and then determine whether there is ST segment depression or T-wave inversion or transient ST segment elevation to find out whether this could be an acute coronary syndrome. If it's inconclusive, remember 30% of the first ECGs could be negative, but still we end up with a diagnosis of heart attack. I have seen 100% occlusions of coronary arteries with normal looking ECGs in the conventional phase. So if you are not sure, repeat the ECG within 15 to 30 minutes. And then if they have ongoing symptoms suggestive of myocardial ischemia, do additional leads, including the circumflex artery, which could be into the V7 to V9, going into the back of the left side. You can look in a textbook, how to place the leads, or suspect right ventricular infarction, looking at V3R and V4R leads. And then if you have ST segment elevation more than 1 millimeter in limb leads, or ST segment elevation more than 2 millimeters in chest leads in males, and more than 1.5 millimeters chest leads in females, these are supposed to indicate nearly 100% occlusion of a coronary artery causing a ST elevation MI and needs urgent reperfusion treatment. And in addition, left bundle branch block, new onset, or ECG changes with a pre-existing left bundle branch block. There's a criteria called Scarbosa's criteria, where you can get concordant ST segment elevation in leads more than 1 millimeter despite the presence of left bundle branch block. This may help detect candidates who needs emergency treatment as a STEMI. And usually people with left bundle branch block and indicates proximal LAD occlusion, and they're very sick to begin with. So well-looking person with a left bundle branch block, you need to carefully ask whether the diagnosis could be correct. But if they look unwell, most likely they might be having a ST elevation MI. Okay, right. So we talked about clinical assessment. We talked about the ECG, which is very important, and within 10 minutes of first medical contact, and then proper assessment. Then, of course, the famous thing for a lot of people is taking the troponin value. Troponin value, I would say, in a resource-limited environment, for making the diagnosis of ST elevation, I don't think we should waste time for troponin at that point. But if you suspect there's another different pathology causing ST elevation, yes, your troponin might be quite useful at that time. But for non-ST elevation MIs, yes, troponin is quite valuable. You may decide to take, if you have high sensitive troponin in your institution, use that after at least 1 hour of onset of chest pain. We cannot take troponin samples, immediately and expect that if it's negative, it rules out coronary arteries. It doesn't. So it's important to give the time frame. And if you have a standard troponin assay, normally it takes about 6 hours for you to rise. If you have the facility to offer 2 troponins, then you can have a baseline followed by a interval troponin, which shows you the rise or fall. So that will give you some sort of idea about whether this could be a MI. But remember, troponin in the right clinical context must be used to make a diagnosis of ST elevation MI or non-ST elevation MI. And also beware when you are calling ST elevation, pay attention to the ECG. Now, these are various types of ST elevation or ST elevation-like states. Okay, the middle two indicate probable ischemic etiology, proper ST elevation. This is showing the more what we call a dome-like or convex upslope upgoing ST elevation is the ischemic ST elevation. What you see here, the saddleback appearance here, with no protrusion there, it doesn't indicate a ischemic pathology. And if you have associated PR interval, PR depression, particularly with the pleuropericardic type pain, most likely the diagnosis underlying pericarditis. And this is often confused by a lot of people. Some people, when their heart muscle, their electrical circuits are wired in a way where you get early repolarization due to opening of the potassium channels during the repolarization phase. And then you get a notch. If you see this notch with ST elevation kind of appearance, it could be a normal variation, what we call a benign early repolarization syndrome or J-point anomaly. So it looks like a fish hook, that's what they say. So get your eyes used to the different kinds of ST elevation, because it could be life-saving in certain circumstances. So for us, it is important to understand the universal definition of acute myocardial infarction. I'm glad to say that one of our PeMSAA alumni, Professor Shanti Mendis, is also in this paper, with the universal definition of acute myocardial infarction. This defines cardiomyocyte necrosis in clinical setting consistent with acute myocardial ischemia. You need to detect either the increase or decrease of cardiac biomarkers with at least one of them above the 99th percentile of the upper reference limit for that particular lab, for that particular group of people. So that's why each lab has in their population set up a cutoff value. And then they should have to show that there's ischemia going on, symptoms, new ECG changes, development of a pathological Q wave. Now, pathological Q wave, remember, in lead V3, less than 25% of a Q wave is not considered pathological. Okay, in other leads, it may be pathological. Imaging evidence of loss of viable myocardium. Of course, this a cardiologist has to do and then detect up a new regional wall motion abnormality on echocardiogram consistent with the ischemic etiology. And then, on a coronary angiogram, if you demonstrate intracoronary thrombus, or indeed, if you look in a patient who had sudden cardiac death and has got thrombus, in autopsy, then of course that is consistent with acute myocardial infarction. Okay, so this is the concept of universal definition of acute myocardial infarction. So think carefully about this when you are calling acute myocardial infarction. Now, myocardial infarction, we subcategorize into several categories. There's at least five types of myocardial infarction based on the mechanism of myocardial injury. the plaque rupture and thrombus formation associated with cutoff of blood supply is the type 1 category. Type 2 myocardial infarction is secondary to ischemia due to increased oxygen demand or decreased supply. Now, this could happen when you have got a fixed coronary artery stenosis without plaque rupture, and then you get a situation where your blood pressure suddenly falls down due to a number of reasons, either intraoperative, etc., or other reasons, or there's severe anemia. So that kind of a situation is called a type 2 myocardial infarction. Sudden cardiac death is, with myocardial infarction is type 3. That's very easy. Type 4 is myocardial infarction associated with PCI or percutaneous coronary intervention. Now, again, this is poorly understood by a lot of doctors as well. Immediately after doing a PCI procedure, if you within the first 5 to 7 days, if you check your troponin, troponin could be up. That doesn't mean that the patient has had a heart attack. To demonstrate myocardial infarction caused by a percutaneous intervention, you need to measure less sensitive biomarker. Remember, troponin, the whole purpose of using troponin is to have a high sensitivity, but whereas here we need to have specificity. So we use CPK-MV generally. If it's more than 3 to 5 times the upper limit of normal, then of course you could call it a substantial myocardial injury, in which case it classifies as a type 4 myocardial infarction. Type 5 myocardial infarction is MI associated with cardiac surgery. Remember, the cardiac surgeon has to touch the heart muscle in order to graft or do things. So in that case, when you handle the heart muscle, invariably there will be troponin or cardiac biomarkers being released. You need to have at least 5 times the upper limit of reference range of CPK-MB to call perioperative around cardiac surgery to have a MI of type 5 category. Okay. So we need to be quite specific about these things for audit purposes, as well as diagnosing and treating, and then triaging patients for life-saving treatment. You need to think about this as well. Okay. As I told you, there's a tsunami of premature heart disease in India and Sri Lanka, happening at this stage, because largely due to the changing in the demographics as well as cardiovascular risk factors and the stress levels, I presume. And consequences of all coronary occlusions are not the same. The treatment prognosis differs very markedly. Now, again, this is another situation where people don't necessarily understand why we do certain things for a certain reason. Okay, the risk of death, MI, in the first year after an index event is proportionately increasing, from 1 or 2 vessel stable coronary disease, particularly if they are non-LAD vessels with coronary disease have the lowest risk, followed by LAD stable coronary disease, followed by 3-vessel coronary artery disease, followed by left main, then acute coronary syndrome, non-ST elevation MI of any vessel, followed by STEMI of any vessel. But of the STEMI, if it involves left anterior descending artery or left main coronary artery, of course, usually the risk of death is very, very high during the index presentation itself. Okay. So STEMI, everybody knows that it's a massive emergency. Early treatment saves lives. What do we do? Medical students, might be the first people, who would notice the STEMI. You must call for expert help early. You cannot, do the basic things and expect the emergency treatment, to come late, because that might kill the patient. So chain of survival is very important. You call experts for help early. Then you start looking at the patient. If the patient's rhythm is bad, if you've got a cardiac arrest type rhythm, you manage that and then get the patient out of that. If the patient is in an arrest situation or a peri-arrest situation, if you need to provide basic life support, you provide that. Give the emergency anti-platelet drugs. There's a plethora of anti-platelet drugs. We will talk about it. You need to provide them with pain relief, oxygen. And then, as a mnemonic, you can remember it's MONAC. MONAC is what we need to give, for your drugs. MONAC stands for morphine, oxygen, aspirin, clopidogrel, or there are so many, or equivalent. We'll talk about that later. So all that, and nitrates. So you can provide all that, and then that is emergency treatment. First line treatment. But definitive treatment means you need to open that blockage quickly. How do we do that? We have either the option of thrombolysis or primary PCI. Thrombolysis is in giving a lytic agent which will try to remove the clot by fibrin degradation. But the primary PCI arm will look at angioplasty options. Let's look at the lytic treatment that is available in Sri Lanka in more detail. Streptokinase used to be the thrombolytic of choice, for some time, but largely now most of the hospitals have gone on to tenecteplase, which is a bolus. I presume you're all familiar with this treatment. It's a weight-adjusted bolus that is fibrin specific, but you have to remember tenecteplase is still ineffective in about 40 to 50% of the cases of all coming heart attacks. And then there are certain subsets where you cannot expect the thrombolytics to work. I will tell you about that in more detail. So choose your tools carefully when you are using thrombolytic therapy. Thrombolytics must be followed with heparin. However, since 2002, we have seen that primary PCI provides a superiority over thrombolysis. Started with the DYNAMI-2 clinical trial, which showed the risk of reinfarction, death, stroke was much lower with primary PCI. Real life data in thousands of patients throughout the world show that you have at least twice the chance of survival at the end of 1 year if you were to be treated by primary PCI rather than thrombolysis. So whenever you have the option of primary PCI, I think that might be a better choice, but you must select the places where primary PCI is offered on a routine basis, and all types of complications can be undertaken expeditiously by specialists. Okay. The European Society of Cardiology gives you this algorithm where if you make a STEMI diagnosis, if you are in reach of a primary PCI capable center and you can transfer the patient 60 minutes, though it says here on this algorithm 60 minutes in Sri Lanka, and it is acceptable to 90 minutes, leaving 30 minutes for the procedure, you should transfer that patient for a primary PCI facility. Okay. And then if you have a first hospital that the patient comes doesn't have the PCI capability, and you cannot foreseeably think that you can get the patient to complete their PCI within 120 minutes, then you should not waste time, but you should go with immediate fibrinolysis with fibrin-specific thrombolytic. But you should not wait until the outcomes are known. You should immediately arrange transfer to a PCI center. The reason being, if the thrombolytics failed, you need to make that assessment at 90 minutes. Thrombolytic failure is described as inability to bring down the ST segments by more than 50% within the 90-minute window. And then if there's ongoing chest pain or arrhythmia, and the patient needs to have urgent mechanical revascularization, that is called rescue PCI, you need to be, the patient has to be in a rescue PCI center. You can't expect to transfer at that moment when you have diagnosed that the thrombolytics have failed. Now recently I came across a patient who had been there after thrombolysis, failed, but in pulmonary edema, left in a peripheral hospital for more than 24 hours, ongoing chest pain, VT. I mean, that this is not the kind of thing that we would want to give our patients. Some people, of course, for various reasons, cannot have treatment on a timely basis, but the complication rates and the healthcare structure really gets crippled because of multiple comorbidities that happen because of late treatment. So it's important to get the patients transferred across. So this we call drip and ship. Of course, the drip and ship refer to thrombolytic treatment given by a drip, followed by sending the patient to a PCI-enabled center to immediately do the procedure. Emergency PCI angioplasty after immediately on the first index presentation is more efficacious, as I told you. Let's see how it works in a practical setting in a primary PCI enabled center. This guy, I met it in 2013. A young man who was waiting for a child to be born, had chest pain, looks like actually epigastric pain, like heartburn like, but if you look at the ECG carefully, there's a proper ST elevation going in the anterolateral leads. I presume all the undergraduates can recognize that this is a ST elevation MI. So we took him the cardiac catheter lab, to get to the coronary arteries. It took about maximum 8 minutes to shoot these pictures, and then you can see this is the left anterior descending artery. It has to be coming around here. There's a thrombus occluding the flow of the contrast dye here. So this is acute thrombotic occlusion. So what do? We put a guide wire through this blockage. Okay. Again, it doesn't take time. This is export catheter going and taking out all the thrombus out. And then this is the thrombus that came out. And then we do a repair job, with the ballooning and then stenting and expand a metal scaffolding to keep the artery open. Blood flow is restored. Job within 30 minutes, the complete flow is restored. Patient ST segments have settled and the rhythm has settled. So this is the patient's actual echocardiogram at time of discharge. You see very good heart function. He returned to office in 1 week. His capacity was, very well, proven on 2 weeks. And then also after 8 years after this index event, I have met him, and then his heart function still remains good, and he's able to run 12 minutes on a treadmill with no problems. So that is the beauty of coronary interventions in the index presentation itself. Okay, so primary PCI must be done, but again, as I told you, timing is very important. Time from symptom to onset of balloon treatment, if it's prolonged, the mortality goes up. So very important. We try to do this as quickly as possible, and try to get the patients across as quickly as possible. But there are certain subset of patients where you think thrombolysis is never going to work. So you need to call for PCI early, where the patient has had previous stent implantation, and then you suspect stent thrombosis, that is thrombus building up within the stent. Very unlikely that thrombolysis will work, because there could be a mechanical issue with the metal framework, or there might be a thrombus that is adherent to the scaffolding. So in which case you must mechanically do this and correct the root cause that's leading to stent thrombosis. So you must, in a situation of stent thrombosis, think for early PCI. If you suspect graft failure, now I have had cases where 26 or 30-year-old, bypass grafts fail, and then you immediately do a procedure and you get better. But if you lyse, then of course, the crud material that is in the grafts are so much that, hardly you will get any reperfusion. And even if they reperfuse, they will go and block the distal coronary circulation, for sure. So this kind of situations sometimes doesn't work, so think carefully whether you can offer PCI as much as possible. Cardiogenic shock. If you have somebody in cardiogenic shock, the chances of the lytics to work and then restore flow is very low. And if the patient has a very high bleeding risk, or the bleeding diathesis, again, think about carefully about offering treatment with lytics. It might actually be adverse to do so. It can make the subsequent PCI also more difficult and complicated, when you have thrombolytics on board. But whatever we do, we need to take the correct decision, treat them quickly. What are the complications that we can expect? We see this in our wards, frequently. You must, if you see a patient who had a heart attack, always listen to the heart and then find out whether there's a changing murmur. Can you hear a rub? Is the patient complaining of faintness, palpitations, low blood pressure, low saturations, or irregular pulse? The reasons why I'm saying this is because of this. This is I think we had a man on Aurudhu Day, last year, who during the COVID lockdown came from Kandy. I think he came from Pera then actually, with a ruptured interventricular septum with a hole in the heart, made because of the necrosis of the left anterior descending artery territory, and a VSD had formed due to the infarct. And this is very, very difficult to manage. Patient becomes quickly desaturated, and then hemodynamic compromise unless treated early. We managed to actually save him after, I think, about 16 days in the ICU, and then managed to get him with surgery and grafting. But it's a battle when this kind of situation happens. Okay. And then your mitral valve apparatus, if the papillary muscles do necrose, they can cause acute ischemic mitral regurgitation. It is very common to see this heart rhythm. You can, I presume the undergraduates can see that there's no significant P wave in this ECG tracing, and the RR interval is variable. That's atrial fibrillation. And then you can see down here, this is non-sustained ventricular tachycardia, potentially life-threatening kind of a arrhythmia. Okay, and then what you see here is a post-mortem finding, free wall rupture and tamponade with blood accumulating in the pericardial sac, and this is heart failure. So if you want to, if you're a Lego Star Wars fan, you can remember as Darth Vader, for all these complications, that can happen post acute MI. Okay, so think about it when you're analyzing a patient. You must also remember, if you subsequently find that you suspected coronary artery disease, but actually proved to be not a coronary heart disease, you also must think why this particular findings, with ECG and cardiac troponin release, happen. It could be in the setting of cardiac dysrhythmia that came as a primary event. It could be because the patient has underlying heart failure. It could be because of hypertensive emergencies. It could be due to shock or burns or sepsis, myocarditis, as I told you, stress cardiomyopathy, valvular heart disease, aortic dissection, pulmonary embolism, renal dysfunction. Even without a cardiac event, you can get with renal dysfunction, acute neurological events, hemorrhage, cardiac contusion, extreme endurance efforts. All these things can cause troponin leakage and minor ECG changes. So you must carefully analyze these patients. We told that if thrombolysis doesn't work, in an acute setting, you have to do rescue angioplasty. And rescue angioplasty actually saves lives. People are very reluctant. Even our cardiology colleagues sometimes, don't like intervening because of the risk of bleeding. But I believe firmly, if you can do your procedure from your radial artery and can manage all the complications, the rescue angioplasty isn't a difficulty. You should, undertake this to save lives. In terms of non-ST elevation MIs, it is very important that we not continuously just see the patients in our clinic and then write some medications and send them home. The reason being, trial after trial and meta-analysis, shows that patients who have early invasive treatment are likely to survive more, and the survival benefit extends over a period of over 5 years. And this is more so for people who have a high risk. Now, how do we calculate high risk? When patients present with non-ST elevation MI, you can use a simple scoring system like Gray score. If the Gray score is more than 140, then it is very valuable for them to have urgent coronary assessment plus followed by intervention. Ideally within 3 days, if you can get this process done, the benefits for long-term preservation of life and reduction of mortality is quite high. Now, when we talk about coronary interventions and do procedures in patients who have heart attacks, sometimes everything is not completely normal or easy. Okay, I showed you some very easy cases at the very beginning, but it could also be very difficult as well. But it is the trick of the interventional cardiologist to see how they can tackle this kind of a problem by creative thinking. So this one was an 84-year-old lady. I did some time back, about 7 years ago. Her diabetes, hypertension, presented with the ACS. Coronary angiogram was done, to find out that you have got severe calcific coronary disease. This is the left main coronary artery, almost like a pinpoint. The shelves up there are calcium. Okay. Patient was referred for cardiopulmonary bypass, but because of age, comorbidity, presentation with the non-ST elevation MI, general frailty, all that reasons, the surgeon declined to operate. Now you can see, if you leave this patient alone and then put on medical treatment and send home, this is going to block in no time or come back with a sudden cardiac dysrhythmia and death. So you cannot, leave this kind of a patient and then say everything's fine, go home and take some tablets, your time is up. So we decided to go ahead and then offer them PCI. But to offer PCI, calcium is our enemy. So we need to get rid of this atheromatous plaque. We did this by rotablation and drilling through the calcified coronary arteries. Now this is the actual procedure. This is a diamond dust, industrial diamond dust carrying burr that spins around 160,000 to 170,000 revs per minute. We just burr through the calcium. The little calcified particles are so small and then gets eaten by the macrophages eventually. We did the left anterior descending artery, then sopped the wires and then did into the circumflex artery, cleaned that up. And then expanded our left main and then stented with 3 stents. Patient did very well. She was able to mobilize next day itself. She lived up to 91 years. About a month ago, she died with urosepsis, nothing to do with the heart. She didn't have a single cardiac event, hospital admission. She had good LV ejection fraction maintained up to the last admission with urosepsis. So these are kind of things that we like to see. A lot of people are afraid of intervening in left main coronary arteries, but if they are done properly and then correctly, then the patients actually greatly benefit from these things. This is another reason why I show this is elderly patients. People are afraid when they are 75. They are afraid to do anything, beyond that. But this is we routinely do 80-year-olds, 90-year-olds. Even my old principal, who came with a massive heart attack, I did at the age of 86. This is another lady who was in a 91-year-old, came with a 3-vessel coronary artery disease with kidney disease, etc. But we revascularized it, successfully without any complication. And this is the lady, after the procedure has been done a week later. So it is very important to not to neglect, elderly patients just because of their age appears to, be in the 90s, but assess them biologically. If it's appropriate, if they have got good cognition, their premorbid status is not too bad, then if you can give them a quality life, by all means, you should think about, offering this treatment to them. Now, coronary disease in the elderly or even in young patients these days doesn't come just with coronary disease. They do come with additional problems. Now, I'm going to talk to you about other additional problems that we frequently come across. Patients come with heart valve problems in addition to coronary artery disease, commonly aortic stenosis. We talked about in the introduction that valve disease also accompanies for a large number of heart failure admissions in our region. So this is about, I think this patient came from Kandy, some years back, 82-year-old, severe aortic stenosis, severe ostial circumflex artery, 99% occlusion, very poor lung function, prior stroke, high risk of death or MACE during open heart surgery. When the patient was offered to a surgeon, they decided it is too high risk to operate. So the patient came to me. I think it was a consultant's father of some description, if I remember. Okay, this is the critical circumflex artery occlusion. Can you see there's a pinpoint-like structure here, just attaching the circumflex artery? That's severely diseased. So we initially fixed that problem, so in a stepwise manner. In the same setting, I passed through the femoral artery and crossed the tight aortic valve, and then did the balloon valvuloplasty of the aortic valve under rapid pacing, cleared it up a little bit, created some space there. At this time, we did not have transcatheter aortic valves, but we brought the technology of transcatheter aortic valves. Now, this is a very interesting and intriguing new technology, new development, which we have brought to Sri Lanka at present. We can, without open heart surgery, we can replace the aortic valve in a conscious patient. So this is how it happens. This is the diseased aortic valve. These are the coronary ostia that you see here, coronary sinuses and coronary ostia. We pass equipment through a 16 or 14 French sheath into the ascending aorta, assemble a valve there, and then cross with the crimped valve using that platform. Then stop the heart momentarily by rapid pacing as inducing ventricular fibrillation type of a thing, and then deploy the artificial valve, crush it against the calcified valve leaflets, and then withdraw the equipment and then restore the new valve. Okay, this can be done in awake patients. This TAVI technology started in around 2008, 2009 in the UK when I was a fellow training in UK, and then transcatheter valves have come a long way, and then at the moment the longevity of the valves are much better than the bioprosthetic open heart valves at present, and we don't know yet the validity against metal valves, but of course the world is going in favor of miniature procedures, and then we see there's a significant reduction of MACE scores or adverse events with transcatheter aortic valves. This is one of our first TAVI valves in that patient I told you. We had gone through the aortic valve, opened the valve leaflets up under rapid pacing. This is how the transcatheter aortic valve goes up. It's got a frame and the leaflets are all fixated inside. Okay. And this is all while the patient is awake. This is the new aortic route with the new aortic valve. This is the usual structure that we use for transcatheter aortic valves. And then we didn't stop there. We progressed on to do the first bicuspid aortic valve, morphologically abnormal aortic valves in a young patient. Managed to do this. This patient came from UK and then actually got the procedure done here. Is doing very well. Then we went on to do our first 5 cases of transcatheter aortic valves under local anesthesia. 4 of the 5 people were over the age of 82, and therefore they were very elderly patients with multiple medical comorbidities, but we managed to get them all successfully done. The last one, he was 85 years old, and then he was able to go and walk in the goal face around, after 5 days after the procedure. So that is the beauty of this treatment. Doing procedures in awake patients with local anesthesia has a lot of advantages for the patient's well-being. We are working on the next stage of these kind of, valve procedures. Valve-in-valve, TAVI, and mitral bioprostheses, when they degenerate, we can actually implant percutaneous valves. We can also do valve within the TAVI, if they were to ever cause problems. We can also fix degenerating valves with suturing defects and then repair the valvular leaks. And we can do many other procedures using this new technology. So it is very important for us to keep going on. We have not just limited ourselves to aortic valve. These days, if open heart surgery is deemed too risky or unfavorable, we can even fixate our mitral valve. Mitral valve intervention is a little bit more costly and difficult, but we do these procedures. The treatment is called mitral clip. You clip the leaking mitral valve and then try to create a new space, as you can see in this diagram. This is a fluoroscopic images of deployed clips in the mitral valve apparatus, and this is how the procedure has been done. This procedure I did it in Hungary along with a couple of other colleagues there. So we do have the option of repairing a mitral valve in surgically ineligible patients. Now, new devices and new equipment to do all this come, and then we have to keep ourselves abreast with the new developments in technology, particularly if you are a young doctor, training up to be a postgraduate and go beyond. Your CME must be updated, and you must maintain your continuous professional development by keeping abreast with new things. These are new adjuncts that are coming into practice. We have had intra-aortic balloon pump. These are hemodynamic support equipment. Impella is very important. Impella is used for situations where your left ventricle or right ventricle, in fact, are functioning pretty badly. And then you have done you are planning to do a definitive procedure like a surgery or intervention, and then you have to maintain the circulation for some time. You can use your Impella devices. You would have heard of VA ECMO. At present, Sri Lanka has only one VA ECMO machine based in Karapitiya, but we need more ECMO. And then tandem heart, LVADs, RVADs, those are important treatments for treatment of heart failure, as destination therapy is limited for patients with heart failure in this country. These things, because of the lack of understanding of things, they're often badly managed even in cardiac wards. These catheters have to be carefully managed. Anticoagulation issues must be looked after. Bleeding from access sites must be looked at, and then using it for the right indications is very important. So it is a must that we know about this and when to wisely use them. Now, coronary artery disease, to a certain extent, the environmental factors and genetic factors would link up to cause problems, but there are certain unfortunate group of people who, due to solely genetic reasons, end up having heart failure. There are treatment available for these kind of things as well, with coronary interventions and structural heart interventions. Hypertrophic cardiomyopathy is one of these targets. If you have a big septal bulge, this is the interventricular septum that you see here. Is almost like 2.5 centimeters, which is like a huge chunky heart muscle. I'm sure you have seen the pathology specimens in the pathology department with hypertrophic cardiomyopathy. And the problem is, when they contract these hearts, there's hardly any space left for blood to remain in the heart and to fill up to properly eject into the coronary circulation as well as the peripheries. You can, with non-surgical techniques, and actually treat these things. If you carefully analyze your coronary anatomy and you select your septal feeder vessels or branches and then inject alcohol. Now, this is a positive use of alcohol in people, okay? You can inject medical grade alcohol down into the septal branches, occlude, and let them have a controlled infarction in these enormous hypertrophic muscles. You can actually ameliorate a lot of their symptoms and reduce their cardiac death risk. So it's very important to do it with echo guidance and proper tools available to treat this kind of diseases. Now, we talked about hypertension as well, as a constitutive factor for systolic and diastolic heart failure. Hypertension management sometimes is very difficult even with multiple drugs, and there's new treatment that are around at the moment for this kind of uncontrollable hypertensive patients. You can actually do renal denervation. The renal nerves supply and regulate the renal blood flow, and then do a big job to maintain hypertension. If you do a selective ablation of the renal artery, renal nerves, sympathetic nerves, you can actually get the resistant hypertension to a more medically manageable condition. So new technologies, new theories are developing as we speak for treatment of various cardiac conditions. This is, of course, an age-old situation. Even today, I did a procedure for a lady who came with ASD, secondum ASDs. We don't no longer need to open up the heart to close all ASDs. You can easily do a good quality device closure. If somebody comes with massive pulmonary embolism post-surgery, you don't just give thrombolytics, and then expect them to bleed. This is a catheter-based pulmonary embolism treatment, that we did for a patient who had gallbladder surgery and ended up having a massive PE. So you can modify, you can use your techniques to treat your patients based on the problem, okay? And then cardiac rhythm issues, we mentioned that the electricals are also a problem in certain situations, and then catheter ablation, CRT, and sometimes leadless pacemakers and devices are coming into a market very soon. So you will see a number of new innovations on the market where you can actually directly implant a device into the heart. Now, this is one of the leadless pacemakers I implanted in one of my patients in UK into the right ventricle. In patients who have got stroke risk because of atrial fibrillation and unusually large left atria, you can also think about left atrial appendage devices to reduce the stroke risk. So treatment is massive, and abilities to select patients for the right treatment is very important. We talked about heart failure patients and complications and how to manage it. There are situations where heart failure has advanced so much that whatever you do, the heart muscle doesn't have enough cardiomyocytes. So we have come across new therapies, and we're actually working on situations as a bridge to cardiac transplantation, how we can improve heart muscle. This work actually stems from my research. The PhD was on stem cell reprogramming and driving down lineages. We have applied this to humans. And then at present, on an experimental level, we have done about 7 stem cell transplantations into patients with severe end-stage heart failure. The benefits of stem cells in coronary circulation is such that they can go into injured tissue by homing mechanisms and then start secreting growth factors and extracellular matrix, and then help the repair process, and also to a certain extent dampen down the harmful inflammatory responses that are taking place in the myocardium. Okay, I won't go into this detail because it's a big area that we need to talk about. Apologies, this is a slide. My son has drawn something here. Okay, right. So This was the first in Sri Lanka experience of intracoronary wire graft injection of stem cells. We went in 2016, actually the first case, for a patient who had a bypass, and the bypass never improved the heart function. The patient was end-stage heart failure, liver failure, and kidney failure all together with one access remaining. So we went in and gave patients own stem cells harvested by stimulating the bone marrow and then taking them out in the periphery and filtering them and then giving them down the coronaries. The patient's heart function improved. Encouraged with this, we went and did a couple of more cases. This was about a lady who had end-stage heart failure due to severe calcific ischemic cardiomyopathy, so much so that she could not be operated. Patient's global LVF was only about 14%. There's hardly anything that you can do, even a surgeon can do in this kind of situation. So we actually harvested the stem cells from the patient's own bone marrow, put them into the coronary arteries. This has to be done very carefully, because the heart function is low. And then the heart function rose to about 36% over a period of 26% over a period of about 2 weeks. That was enough for us to go ahead and then rotablate and then stent her main artery, the left anterior descending artery, and then that improved the heart function further to 36%. So as an adjunct to definitive treatment processes, we could use this technology. We presented these findings in 2018 in San Diego in USA as a challenging case, and then that was accepted for the abstracts. So treatment now, we have extended it to dilated cardiomyopathies, patients who have got defective heart muscle. We have taken stem cells and injected into their hearts with the expectation that heart function will improve. We've had positive improvement, in many of them. And then subsequently, the only question we have is how long this effect lasts, and then how often do we need to do this? Of course, work is going through, but that is another aspect of this research that we are conducting, particularly because, cardiac transplantation is not available widely in Sri Lanka. Only one case has been done so far in Kandy. And then since then, people with heart failure do not have the option of having a new heart. So we have to look at other therapies that can keep them alive and then provide them a reasonable outlook. Okay, so moving from heart failure and then interventions and research aspects, it is also important for us to realize that cardiovascular medicine is a very actively researched area in terms of new medications, and new publications for medications and modes of action keep coming in. So you have to keep yourself abreast with the new developments in cardiovascular medicine. As of 2018, there were 200 cardiovascular medicines in development, imminently waiting to come into the circulation, because I see there's a lot of new things that are happening every year. So you must know the ins and outs of these medications by the time you're a junior doctor. I'm sure you'll encounter new medications already in treatment with patients. We'll take anti-platelet drugs and anticoagulants, because there's a new number of medications there. I presume you're all aware of aspirin, your good old aspirin, and then clopidogrel, which is ADP mediated through the ADP channels as a dual antiplatelet therapy. But clopidogrel alone is not the antiplatelet drug of choice. Sometimes, prasugrel, ticagrelor, and cangrelor is an intravenous version of this. These are available. This is in the world, and it's certainly the first three are available in Sri Lanka. Fourth is pending to come in. So antiplatelet drugs, and then these two pathways, the ADP receptor-mediated activity and thromboxane-mediated pathways, eventually affect the final pathway of platelet aggregation. And 2B3A inhibitors are powerful tools that you can use even in a teaching hospital where a patient is pending and waiting for urgent PCI. You can use this to buy time. Okay, tirofiban and Riopro. These powerful drugs that can be given as intravenous drugs. They prevent the platelet component, platelet aggregation that leads to a clot formation. On the other hand, clot formation also needs fibrin. So fibrin is the target for thrombolytic agents. But to make fibrin, from fibrinogen, you need thrombin. Thrombin can be inhibited by unfractionated heparin and bivalirudin. Bivalirudin is very useful in situations where patient has got a known contraindication for heparin. Some people develop heparin-induced thrombocytopenia. So in this kind of situation, you can use these additional drugs. And then also you can affect through your 10A pathway prothrombin, by using enoxaparin or fondaparinux, or your apixaban, edoxaban, or rivaroxaban. Now, rivaroxaban and apixaban are currently available in Sri Lanka. So those are new novel oral anticoagulant agents. They mediate the effect through factor 10A. Okay. And then your classical warfarin-like medications acting through the vitamin K pathway activate multiple factors in coagulation cascade. So remember, there's a lot of development that is happening in this area. You must keep abreast with these things because they are imminently waiting to be coming into patient practice by the time you graduate. So this is just a slide of current usage of anti-platelet drugs with fibrinolytic therapy or without reperfusion therapy. And then how much should you use unfractionated heparin or bivalirudin or enoxaparin. And then you must also think about the other medications, the secondary prevention. The lipid management is an important aspect of secondary management of patients with coronary artery disease. The number of drugs that have been developed in this area is tremendous. We used to have the HMD-CoA reductase inhibitors, the statins. And then also we used to have the fibrates, as our only drugs available when we were medical students. But now there are so many other drugs. Ezetimibe as an absorption inhibitor is there. Bile acid sequencers and the cholestyramine, kind of drugs are available in Sri Lanka. PCSK9 inhibitors, these are available in Singapore and other countries, and I think imminently it will be available in Sri Lanka as well. These are injectable lipid-lowering medications, quite costly, but certainly works very nicely in patients who cannot tolerate other drugs. Then bempedoic acid, is coming into publications, this year onwards. We will see a whole heap of other drugs that are in development and then in clinical trials. So please keep yourself abreast with new developments in cardiovascular medications. In terms of heart failure targets, and this is one of the areas that has rapidly grown over the last few years. These are the trials with a positive impact on heart failure patients, trials which have showed no long-term benefit in patients with heart failure, but the current database suggests usage of ACE inhibitors and ARBs, beta blocker, mineralocorticoid receptor antagonists. Those are the aldosterone-like inhibitors like aldactone or spironolactone or eplerenone. The neprilysin inhibitors, angiotensin receptor blockers, ARNIs or SGLT inhibitors. Those are sodium channel blockers are very important at the moment in terms of managing heart failure. So much so, the SGLT2 inhibitors like empagliflozin or drugs of the gliflozin class have actually come as step one to be initiated with beta blockers alongside beta blockers in patients with diabetes and without diabetes. Okay, so changing paradigms, you need to be keeping updated with management of heart failure patients. But heart failure management is not just prescribing a couple of pills and then hoping that the heart will get better. No, the heart needs blood supply. Heart needs valves to be proper. Heart needs the rhythm to be proper. Heart needs the other systems, the endocrine system to be proper. Heart needs nutrition. So all these things you must take into consideration when assessing a patient with heart failure. So for mitigating heart failure, the best thing is to look for the biggest possible targets. So the strongest factors that are associated and are associated with the highest reduction in mortality must be looked at first. So no surprises here. Coronary artery disease. If you have underlying heart failure and coronary artery disease is likely to be the culprit, revascularize them. That gives you the best possible chance of coming out of it. If you have aortic stenosis, yes, look after your aortic valve and then try to replace it. That gives you a best chance of getting the patient out of heart failure. If you have diabetes, treat that aggressively. If you have kidney disease, treat that aggressively. If you have chronic lung disease, treat that. That gives you a better chance of preventing right heart failure. If you have mitral regurgitation, treat that. It will improve the left ventricle hemodynamics and shape. If you have other risk factors for prevention, treat them. Even simple things like anemia, iron deficiency, sleep disorders, thyroid problems, treat them. Because this slide, I think, is very important. A lot of people forget that heart failure is a multi-modality, multi-etiology problem, and the best chances of you for keeping the patient out of trouble is to address the underlying causes. I often see patients being left in the medical clinic with heart failure, come into the clinic after clinic after clinic, without ever getting better, simply because without any addressing of the underlying problems like coronary artery disease or valve disease, they have no chance of getting out from their misery. So we have to select patients and then treat them in a timely fashion. And as for the undergraduates, it's very important that you play your part as a junior doctor or an undergraduate or a medical student. If you come across a patient with heart attacks or had a cardiac arrest, call for help early by early recognition and then understanding the pathophysiology behind it. Okay, if you can prevent cardiac arrest, that's great. But if they do go into cardiac arrest, provide good quality CPR to buy time. Call for help early defibrillation. Even in the community or in your hospital. Treat them, get the patient's rhythm back, and start good quality post-resuscitation care. But post-resuscitation care doesn't mean that you put the patient in the ICU and forget that there's an underlying etiological reason that led to the problem in the first place. The idea should be to have a quick discussion about the best possible course of manner with expert help. If the patient's best chance is actually early intervention and doing something, pick up a phone and then call, because that gives you the best possible chance to restore patient's long-term outcome. So with that message, I leave my contact details to anybody who's interested, who wants to get in touch. And I would, without a doubt, extend my sincere thanks to the current PeMSAA president, Professor Tushara Kudagamana, and all the council members, some of them who are my esteemed teachers, Dr. Niranjan Disanayaka for bringing a friend and then extending the invitation to address you today, Dr. Kasun, who managed a lot of logistical things, and all the participants here in this forum today. And I also want to end up by giving a special tribute to my cardiology inspiration in life, Professor Tissa Kappagoda, who I'm sure Niranjan will remember, used to give us lectures as final year medical students, coming all the way from USA and inspiring us to study and then think beyond our boundaries about how new technology could be adapted. And also late Professor Varugunam, who used to be in the grand rounds until he was of a ripe good old age. Along with them, all my teachers of living today, including Professor Chandraratnatunga, who was a lead teacher of me, as well as everybody else in this forum today. I greatly appreciate what you have done for myself and my colleagues. I'm sure you are doing a good job for the current undergraduates as well. Thank you.
Yeah. Thank you very much, Pandula. I think we were privileged to listen to one of the most comprehensive discussions and presentations regarding cardiovascular diseases, starting from the simple things up to the to the very complicated. And as you said, I think we should think beyond our margins and beyond our expectations and think big. Unless that happens, we will, as a country, even as specialties, we will be in a very, very limited space. So updating our knowledge and thinking about the things that we can do for our patients, I think it will be the most important thing that we have to think of. And I'm really, really happy that you accepted this invitation. And I think that many of the students who listened not only gained knowledge but were inspired to reach higher heights in their medical careers. So if I may, I think there are some questions that have been posted by students, and I think one of the questions that I would like to put to you is that from a student is that in a patient who should they all undergo coronary intervention at a later date, and if yes, what is the usual time to do so? Um, TRC, is
The
there a
simple,
difficulty in connecting?
yeah.
Hello?
No,
Yeah.
Rajan, I can hear you. Can you hear
Can you hear
me?
me?
Yeah, I can hear you. Can you hear me?
Yeah, now it's clear. So there are
Okay.
some questions,
So
Pandula. Yeah, I
yes, I
can
can
hear you
see
now.
that.
Yes.
I can
Right.
see that.
So
Now, as I
okay, right.
explained in the I explained in the presentation itself, patients who undergo STEMI, thrombolysis is not the definitive treatment. Thrombolysis is merely addressing the emergency situation to buy you time. So it disperses the clot that has built in there. But the reason that led to the clot formation could be a ruptured thin capped fibroatheroma that has broken and exudated all the lipids. It could be a coronary artery dissection. It could be a high-grade plaque that is blocking the blood supply. And then if you don't offer treatment in terms of definitive coronary angiography and treatment, then there's a very high chance of frequent future events, reinfarction, cardiac dysrhythmia, heart failure. And I showed you the graph, a graph where, if you have early revascularization within the first 24 to 48 hours after the index presentation, or at least by 3 days, you generally have a much higher chance of making the patient's cardiovascular risk over the 5-year period much lower. So in summary, everybody who has had a STEMI and had undergone thrombolysis, unless there's a contraindication, for instance, they have end-stage renal failure, end-stage multi-organ disease, something there, the quality of life is so poor, etc. That kind of a situation, unless that kind of situation precludes the patient from using valuable resources, then I think they should all have a coronary angiogram as a basic minimum to risk weight. If the patient has a proximal LAD lesion or a left main or multivessel coronary disease or an unstable lesion, they should have it fixed before they resume back to work or have their normal physical activities being undertaken again. So for that reason, it is essential that they have this treatment done. But for logistical reasons, the resources in Sri Lanka are limited. Financial difficulties exist, but to be honest, I feel that it is a relative statement. A lot of people buy expensive TVs for or cars or resources for their houses or something like that, but actually when it comes to a heart attack, they don't actually think that is needed to treat. And certainly the hospital system also tends to encourage more patients to come to the clinic rather than resolving the problem in the index period, because it involves a lot of logistical transfers, difficulties, etc. But to be honest, what we should be working for is every person who's had a heart attack should be offered coronary imaging, coronary angiogram preferably, because CTs, as I told you in STEMIs, sometimes can be misleading. And then a decision about need for management with medical therapy or revascularization be undertaken after having looked at the coronary anatomy.
So Pandula, it should be done at least within the first 4 weeks after the STEMI?
Ideally 3 days, STEMI,
Ideally 3
STEMI,
days.
is an
Right.
emergency. 3 days, is the ideal cutoff. But as soon as you possibly can, it saves lives. There's no question about it.
Okay. So as soon as the thrombolysis happens, as soon as the patient is stable, it's better to go for a coronary angiogram as early as possible.
Yeah,
Right.
even though I would say not even wait until the patient is stable, because stability might not happen for a lot of patients. You realize
Yes.
that, as I told you, 25% of the patients might die, without immediate treatment. So the best thing is to start the treatment, and then, with ambulance services, is transferred to a hub where you can actually do something, invasively if the patient became unstable. There's no point in holding on to the patient, and then ending up with a dead patient.
Yes. So, and there is another different type of a question regarding stents. I think that's a very interesting question. So I'll ask it from you. How to decide whether you are putting in a drug-eluting stent or a non-drug eluting stent?
Yes, I mean, this used to be a historical question, and this is actually now a historical question. But in the past, it used to be that bare metal stents could be used with a shorter dual antiplatelet therapy and regimen, and it used to be less expensive than drug-eluting stents to implant. But the prices of the stents and equipment are more or less these days not a huge difference. If you look at it, in most of the national hospitals, etc., the cost of a drug-eluting stent and a bare metal stent are almost equal to one another these days. And the longevity of drug-eluting stents are better than a bare metal stent. Now, interestingly, there are various flavors of drug-eluting stents these days. The bigger problem that we used to have earlier was, if you have a drug-eluting stent of certain kinds, you will have to use a prolonged dual antiplatelet therapy regimen, and if they were to have a bleeding event or whatever, could we actually stop the medications? Now, there are certain drug-eluting stents available at the moment which require a minimum of 1 month dual antiplatelet therapy because it heals faster with this kind of stent designs. There are stents without a polymer. There are stents with rapid strut coverage. You can pick and choose depending on the patient's condition. For elderly patients and patients with a high bleeding risk, we generally select drug-eluting stents that require dual antiplatelet therapy only for a month. And then, if the bleeding were to occur, then we can manage that. And if the patient cannot tolerate that, there are certainly other options. You can have balloon angioplasty and drug-eluting balloons to be delivering drug directly onto the surface. There are certain technological advances that are there that you can use in this kind of situations.
So basically, I think now regarding when you think about the prices as well as the need for dual platelets, there is no significant difference between those two groups.
At the moment,
and so you prefer to,
because it is advanced.
So you prefer to go for a drug-eluting stent in most instances.
To give the best long-term outcome if you can.
We have to go for that. Okay. And there is a different type of a question, I think, because it was not touched, I will discuss with you regarding a very important thing, peripartum cardiomyopathy. And, this student wants to know what is peripartum cardiomyopathy and what are the symptoms and signs that helps us to diagnose these patients.
Correct. I mean, certain number of pregnant ladies, will end up developing progressive heart failure. And it happens, they think, this is because of the underlying immune dysregulation, either due to escaping fetal material or due to cytokines, that are coming into circulation, which are specific to the placenta and the circulation, ending up having a cross reaction with the heart. Whatever is said and done, the presentation is a progressive breathlessness, ankle edema. Now, you have to remember that, it might be very difficult in certain heavily pregnant ladies to distinguish whether this is due to varicose veins or whether this is due to peripartum cardiomyopathy. They all have breathlessness. They all have got ankle edema. Many of them have hypertension and then heart failure. So you need to be able to work that out. But the hallmark is to have a good quality echocardiogram. And if you have a good quality echocardiogram that shows reduced left ventricular ejection fraction, longitudinal strain being abnormal, you get the picture of a dilated cardiomyopathy, then of course you have to suspect peripartum cardiomyopathy as a possible diagnosis. So obstetricians will tell us the best treatment for peripartum cardiomyopathy is to get the baby out as quickly as possible. Now, of course, it's easier said than done, because the maternal and fetal well-being has to be carefully discussed between the treating cardiologist as well as the obstetrician. So if the patient, the baby can be managed outside, then of course, the push is to have early treatment, because that reduces the strain on the heart as well as take away the element of cytokine mediated damage that is happening to the heart. And thereafter, it also gives us a chance to start on heart failure medications that will help us to try to minimize the damage that is happening to the heart. So as you know, ACE inhibitors, beta blockers, can cause intrauterine growth retardation and then cause various complications in the babies, unborn babies. So if the baby is out, then it gives more opportunity for the patient to receive timely treatment to reverse the peripartum cardiomyopathy.
Yeah. Yes, Pandula, as you said, in pregnancy, you can get the normal shortness of breath of pregnancy, and sometimes it's very difficult, and some of these patients comes to me thinking of asthma as well. So as a routine, even though I'm confident that the diagnosis is asthma, I usually ask for a 2D echo and a cardiologist opinion before confirming my diagnosis, because in pregnancy, assessing shortness of breath is rather tricky. So you should not miss anything. Right. So there is another important question regarding arrhythmia. So I thought that we will cover that as well. So when a patient who has mitral stenosis presents with onset of atrial fibrillation, I think what he means is that new onset atrial fibrillation, what is the first thing that we have to do? We have to give IV digoxin for rate control or amiodarone for rhythm control.
Yeah, good question. Now, you have to understand, what you are going to treat and what your targets are. So if it's new atrial fibrillation without valvular heart disease, okay, the management is different compared to a patient who has atrial fibrillation in the context of valvular heart disease such as mitral stenosis. Okay, if you have mitral stenosis, there's a good chance that this arrhythmia, though it was discovered at this time, it could have been happening on a paroxysmal basis. That is one of the possibilities. Secondly, the left atrial appendage is quite not normal in patients who have had mitral stenosis. You might find that there might be a big thrombus sitting in the left atrial appendage. So in this kind of a situation, unless careful assessment is been done by a transesophageal echocardiogram to look at the left atrial appendage and rule out thrombus, it might be a little bit of a tricky situation to try to cardiovert the patient with amiodarone or electrical cardioversion, because the thrombus can easily dislodge and cause an embolic stroke or complication elsewhere. So in my mind, if somebody comes with long-standing valvular heart disease and atrial fibrillation, the better strategy for us is to anticoagulate and then control the rate. Now, the rate control can be done in a number of ways. It could be digoxin, it could be a beta blocker. If the heart function is good, it could be a calcium channel blocker. You can control the rate so that the patient doesn't experience the symptoms of heart failure, but you buy time by properly anticoagulating. Once the anticoagulation has been done, and then you achieve proper anticoagulation with the help of NOAC, as I told you, with edoxaban, rivaroxaban, or apixaban, or your usual warfarin, then you can plan to definitely treat it. Either you can try to cardiovert this patient electrically or with amiodarone, and then then thereafter you can think about addressing the cause either by going ahead with a balloon valvuloplasty to relieve the mitral stenosis, or implanting a valve, and then ligating up the left atrial appendage. So the whole purpose of this is to prevent complications happening during a cardioversion in a patient with known rheumatic or mitral valvular disease with potential clots in the left atrium or the left atrial appendage. So I think the strategy of rate control is right, but you have not just digoxin, you have got many other agents there, and the urgency for treatment with IV or oral, because remember oral digoxin bioavailability is almost similar to the IV. IV is used when you need quick onset action if the patient is very unstable, but you can equally achieve by good oral loading doses if you have access to that. You can also choose calcium channel blockers, or you can use beta blockers if there's no contraindication. Hello, can you hear me?
Yes, yeah. Sorry, I have muted myself. Sorry.
Okay.
Right. Anyway, yeah. There is one question, Pandula, asking about the antihypertensive treatment in STEMI patients. Which I thought that I think you can highlight some important pathological and underlying pharmacological reasons. So the question is that what is the initial drug given in hypertension for a STEMI patients in the initial presentation?
Okay. So in a STEMI patient, as I told you, the big fives in any patient with STEMI, there's a drug sequence that you need to act. Your anti-platelet drugs, your beta blockers, your ACE inhibitors, statin, and anticoagulation. And then nitrates. Those are the important drugs in that sequence. But if you have got a patient with a STEMI in the setting of hypertension, normally, you need to bring the blood pressure down for your thrombolysis, or to, facilitate coronary intervention. In that kind of a situation, if it makes logical sense, if you were to use a nitrate and then intravenous nitrate to bring the pressure down in that kind of an acute setting, it causes vasodilation of the coronary bed, supplies and keeps the viable myocardium somehow alive until you get the definitive treatment done. At the same time, the patient is not in pulmonary edema, beta blocker could be life-saving, because the pathological arrhythmia that is associated with STEMIs, ventricular tachycardia, ventricular fibrillation, can be mitigated. But beware, if the patient is already bradycardic or has got heart block as a consequence of an inferior MI, if you give beta blockers, of course, you can actually end up with more problems. So you need to be wise about these things. Okay. And then once the STEMI has been treated, then of course the target is to initiate antihypertensive drugs, that will affect the left ventricular remodeling. So you need to start on an ACE inhibitor and MRA. MRA is, as I told you, spironolactone or eplerenone to prevent adverse remodeling of the heart within the first 24 hours of the infarct. If you can start them, then there's evidence to say that there's long-term benefits. So that is how I view it in the context of a STEMI.
Okay, and I think there are some questions about coronary, interventions. So I will just pose some questions to you. There's one question saying that the patient who has stable angina with a 80% block in right coronary artery, whether he needs PCI or whether it can be compensated by the collateral supply.
Yeah, good question, because I see this happening most of the time. Actually, I didn't present a slide. A stable coronary artery disease is not always stable. You have to remember that. If you have got a large right coronary artery, and that right coronary artery is likely to subtend more than 10% of your myocardium, then your cardiovascular event rates, are actually statistically very high. It goes above by 7 to 8% or more for a patient who has got a myocardium more than 10%, having reduced blood supply, antegrade blood supply. So even though you have collaterals are by no means a guarantee to, keep physiological function. Collaterals will merely help to keep the heart muscle somehow, drilling along a little bit, but there will be chronic ischemia, chronic fibrosis taking place, chronic exercise-induced ventricular tachycardia. All these things can take place. You have to remember also the patient's age and their level of activity when you are dealing with this. Suppose you have a 95-year-old, patient who's, having a very limited mobility and bedridden, and then doesn't use things much. He just, basically gets out of the bed and then gets back into bed. That kind of a person having a single vessel coronary artery disease like this might not put him at a substantial high risk of a major complication. And in any case, his quality of life is poor. But if you take somebody under the age of maybe 65 or 70, and then they have to run about, do some work, look after their grandkids, go to do their shopping, etc. These guys, or do some gentle exercise to keep their levels fit. if you start doing that, you're bound to get ischemic complications. So if you have a high-grade lesion supplying a large right coronary artery, then it is very important to get it revascularized. And then right coronary artery, remember, it is not just the heart blood supply itself. More importantly, the conduction system of the heart is dependent on the right coronary artery. So you can get a AV block, you can develop a need for a permanent pacemaker if you don't treat the coronary artery disease on top of everything else. So why get into that situation is my question. If there is substantial coronary artery disease, even though you think it's stable, you need to make an assessment of the severity of it. You can exercise and then demonstrate presence of ischemia. You can do a pressure wire study to assess the extent of ischemia. You can do a myocardial perfusion scan and look at the extent of heart muscle that is involved with this ischemia, and then make your judgment based on that. You shouldn't just just for the sake of it, you shouldn't either decline it. But in my honest opinion, if you're a young, fit, healthy, young means, for all intents and purposes, under the age of 70 in this kind of a situation, if they are independent, they probably should get it revascularized.
Yeah, so it's basically, rather than going according to the number, percentage of obstruction as well as the vessel that is involved, you are thinking about the clinical aspects as well as the future risk and the patient's well-being in the future as well.
Absolutely.
Another question regarding that is that in a patient with mild left anterior descending obstruction, mild descending, whether we can manage only with drugs or do we need intervention there?
Yeah, again, the same answer again. You have to assess whether the mild coronary artery disease is actually producing ischemia or ischemic related complications. So if the patient hasn't had a coronary event like acute coronary syndrome, and it's mild bystander coronary disease, which doesn't produce ischemia, simple primary prevention or secondary prevention using a statin, a single antiplatelet drug, and a single other agent, should be more than adequate to, control, the risk posed by simple lesions. But on the other hand, if mild diffuse coronary, remember, sometimes angiograms are poorly being analyzed even by our cardiology colleagues. It can happen because tube-like coronary lesion, could be easily be interpreted, saying that, it is a normal for this patient. But actually, if you look at it, from there are certain telltale signs to say this vessel should be something much bigger than this, and it looks like a little tube from top to bottom. And then this kind of a person, might present to you with a positive exercise test, ischemia, in another functional test. So then in that case, it's wise to actually take another look, either by doing a pressure wire study or putting an intravascular ultrasound camera down the coronary artery and then actually taking a look and seeing what is there. You might find, to your surprise, that the whole artery is, full of atheromatous gunk, which is causing substantial plaque burden. In that case, of course, revascularization that patient is important. But on the other hand, if it's just mild focal coronary disease that is there with no consequences, then of course, simple medical therapy to prevent the situation getting worse is more than adequate.
Yeah. And Pandula, there is, I think, one question. It's a practical question. One of our students, I think, we can answer it in the Sri Lankan context, what we have, the drugs that are available. So what he's asking is that what are the drugs that are available and to be given to a patient who is planning for a primary PCI? Patient presents with MI. Yeah.
Okay. So if they come with a STEMI and then you are trying to send the patient for primary PCI, aspirin is a must. So aspirin 300 milligrams, we give it, by chewed route. Okay. That gives you the fastest access to the circulation. Okay, if you can chew it and then ask them to, even 300 milligrams, even if it's a coated aspirin, doesn't matter, ask them to chew it and then take it, so it gets absorbed quicker. If you use your old clopidogrel, which is widely available in the hospitals, use 600 milligrams of clopidogrel. Okay, 600 milligrams is an appropriate loading dose for going for primary PCI. If you do know that the patient has got, substantial coronary artery disease, and have some sort of idea about the coronary anatomy from previous studies or this index presentation, and then that you're going for a PCI, definitive PCI strategy, prasugrel, has been shown to be actually the most effective drug because it is a direct drug. It doesn't have to undergo metabolism in the liver, and then reaches the circulation quickest, So in that kind of situation, it's very advantageous to have that drug upfront, so you can mitigate the small risk of acute stent thrombosis in patients with poor circulation. And in other patients, then ticagrelor is quite useful. Now, if you want to use prasugrel, give 60 milligrams of prasugrel, as the loading dose. If you want to, use a drug that is slightly, we don't know the coronary anatomy, we don't know whether the cardiologist might be able to operate on this patient, or whether the patient needs to end up, having a bypass operation. Of course, that's very unlikely in this days and age, because bypass doesn't have a favorable situation in a STEMI situation, primary PCI. So in that kind of situation, if you have doubts, and then you know that the patient has got known triple vessel coronary disease with calcification or whatever, you may end up giving ticagrelor 180 milligrams, because the offset of ticagrelor can be faster than the other two drugs, in case if the patient needs to have surgery. So that is how I would think about it. And then if you have a patient, despite these two primary antiplatelet drugs, aspirin and one other, seem to be quite unstable, and you are thinking that the patient is unlikely to make it to the PCI facility in time, or even thrombolysis is unlikely to work in this kind of situation, then you could potentially consider the option of 2B3A inhibitors, that is Riopro or tirofiban, if it's available in your hospital. And then with the weight adjusted dosage, you can have an intravenous infusion of that. Or you can give unfractionated heparin, a single dose, or easier than that, you can give bolus heparin of 2,500 to 5,000 units, depending on the time you think the patient is likely to get for PCI. Okay. But on the other hand, if you think you cannot get the patient to the cath lab within a few hours, and then very unlikely that they are going to have a major bleeding problem, then of course think about thrombolysis, and then initiate the journey to the cath lab facility. That also will sometimes help to disturb the clot.
Yeah, Pandula, I think we should go into the final question now. I think that's a very interesting question. I think this is a very practical question as well. Now, what are the principles of management of a STEMI patient who is on cardiogenic shock, basically, if the patient is hypertensive?
Correct. Now the patients with STEMI, in cardiogenic shock have the highest mortality, amongst all the patients. And every 30 minutes, if you delay it, there's fourfold, there's said about 30 to 40% increase in the mortality every half an hour that you delay the patient's transition to definitive treatment. As I told you, thrombolysis, is very poorly, working in patients with shock. So your immediate plans would be to try to counteract the shock status. You can use temporarily your inotropic drugs, preferably dobutamine in combination with noradrenaline. But remember, these are arrhythmogenic drugs, so it has to be used at the basic minimum drug concentration that you can use to maintain the blood pressure. Secondly, if you have access to a C-arm, I think, even Peradeniya Hospital has a C-arm. If you can get an intra-aortic balloon pump, inserted through the femoral route and then get it parked. The intra-aortic balloon pump is a counterpulsating device which will, according to the ECG, augment the diastolic pressure that will perfuse the coronary arteries selectively. So that kind of a device, will buy you time in high-risk patients, so that your pressure during diastole will be higher, coronaries will be perfused better, and the shock state will start improving soon. Okay, and then thirdly, you also need to get your antiplatelets in quickly. And then, as I told you, direct drugs such as prasugrel, might be more appropriate, because I don't think in a shock situation drug absorption metabolism works very well. So in that kind of a situation, clopidogrel has virtually very low chance of actually doing something positive to disturb the clot formation and increase the flow. So you might want to consider giving upfront heparin, and then giving drugs that directly affect and then get absorbed into the circulation. And then you need to be getting on with your friendliest interventional cardiologist to quickly get the patient to that facility as quickly as possible, because they must undergo emergency primary PCI with the help of a balloon pump if needed be for treating the shock and revascularization.
Okay, Pandula, I think so. We have some other questions left, but I think in space of time, I think we might not be able to answer them. But I think you have given the email address. So if students can send the questions to you via email, I think you will be more than happy to answer them in individual basis as well, whenever you have time, even though I know that you are a very busy practicing clinician. And I know, and Pandula, I think so we will finish this presentation now, and I think I would like to thank you again for your for the excellent presentation, a comprehensive presentation, one of the best that I have heard so far in cardiology, right? And I think the students would have been benefited much than me. I'm being a pulmonologist. Anyway, I think it would have been important in their day-to-day practice as well. And hopefully, I think as we discussed earlier, we were able to show them that we have a huge potential, even in Sri Lanka, to improve our clinical practices than what we do at present. And especially as a Sri Lankan, I would like to thank you especially, and in front of all the students. I know that you could have worked in any other country, any developed country, and would have had a better life with your family in any other country. But I would like to thank you for coming to Sri Lanka, coming back to Sri Lanka, and giving the services to our patients without any hesitation. Thank you very much, Pandula.
Thank you very much, Ranjan. Thank you, PeMSAA. Good luck, everybody.
Okay, bye.
Bye.